and excited Dr. Zinzi Bailey, who is a social epidemiologist and an assistant professor at the University of Miami Miller School of Medicine and the Sylvester Comprehensive Cancer Center. Her research focuses on operationalizing historical and contemporary structural racism in relationship to health inequities, namely reproductive and lung cancer disparities across the cancer continuum and disparities in aging. Prior to moving to Miami, she was the Director of Research and Evaluation at the Center for Health Equity in the New York City Department of Health and Mental Hygiene. Dr. Bailey serves as not only a board member of Florida Health Justice Project, but also an associate director to the Robert Wood Johnson Foundation's Interdisciplinary Research Leaders Program, and a mentor for the Health Policy Research Scholars Program, also funded by the Robert Wood Johnson Foundation. And as I said, it's my pleasure to turn the floor over to Dr. Bailey.
Thank you so much. I'm going to get our presentation up as I will say the key words of this age, which is let me get my presentation. I'm like, let me share my screen. And so let me do that. But thank you so much for the invitation and for all the people who made this possible. Essentially, I want to thank, Jennifer, Tobin and others on the search committee, Ginger, who, helped coordinate a lot of elements of this visit, and for you for attending this talk. And hopefully it will be interesting and something thought-provoking and something that we can start discussions with. It's by no means all-encompassing, but I think it will start conversations and start potential collaborations. So I'm really here to delve into one dimension of my research portfolio. And I have a larger body of work focused on lung cancer disparities and smoking. But for the large part, I'm not going to be delving deeply into that. Instead, I'm focusing on how we can capture structural racism in health equity research. I'm particularly interested in operationalizing the impacts of structural racism and how that impacts population health inequities, not just for the novel nature of the science, right? But so that we can create opportunities to develop structural solutions for community wellness. This requires broad theoretical work, in-depth methodological work, and community-engaged work for change in action. And so in the next 40 minutes or so, if we're lucky and I speak fastly enough, I'll be delving into the nature of racial and ethnic health disparities, inequities in the United States in order to unpack some of the key theoretical foundations of the work and contextualizing these inequities in relationship to systems of oppression. I will then delve into a few empirical examples of operationalization of structural racism in population health science, including some of my work. And then I'll wrap up by sharing a few works in progress. And for the sake of flow, I'll hold the questions and comments until the end. And so I think it will not be of great surprise to all of you that the United States has the dubious honor of being a world leader in health inequity. Not something that we really are proud of, but something that we can really start really tackling. And we have a number of opportunities, let's say, right? And if we focus on differences in life expectancy as a key global measure of population health, whereby even a difference of even a year reflects decades of change, the bad news here is, for example, there's a consistent gap in life expectancy between Black and white Americans that has existed for centuries, right? The good news is that between 1990 and 2018, this gap fell by about 48.9%, before stalling a little bit in 2012 and increasing somewhat during the pandemic. The causes that contributed the most to Black Americans' mortality reductions includes improvements in cancer, homicide, HIV, and causes associated with the fetal and infant period. And while I do work in HIV and aging, much of my work is really focused on cancer disparities. However, the whole point of this is that these focus areas are relevant based on their contribution to overall community health and health equity. And as a social epidemiologist and public health practitioner, my goal is really thinking about health equity. And so health equity is achieved when every person has the opportunity to attain his, her, their full health potential, and no one is disadvantaged from achieving that potential because of societal or social position or any socially determined circumstance. Health disparities or inequities are reflected in differences in length of life, quality of life, rates of disease, disability and death, severity of disease, and access to treatment. But this does not mean that health equity is simply its inverse. Health equity looks not only like equality in outcomes, but also equity in the process. Interventions to address health inequities can be conceptualized as occurring somewhere along this kind of continuum. So we can think of upstream, downstream factors, or somewhere in between. And downstream determinants occur on individual levels more generally, including individual biology and specific risk factors and behaviors. And intervening on that level will help individuals, and perhaps, particularly in a clinical context, but it doesn't really address factors upstream that are driving these patterns, read inequities, in health behaviors, outcomes, and biology. So going further upstream, we can find living conditions, which include physical, residential conditions, social environments, work environments, and service environments. And this can be characterized in a number of different ways. And so, for example, if someone lives in a place that is under-resourced to address common pests, for example, living in public housing, that person is more likely to encounter asthma triggers and experience asthma attacks and require emergency room or emergency department care. Often we call these kinds of things social determinants of health. And we can intervene on remediating an apartment or home or increasing access to insurance. However, this is not getting at some of the systematic reasons by which public housing translates to poor built environment, and by which that individual needs public housing in the first place. So for me, the question is, why are certain living conditions more prevalent among certain populations or certain communities and not others, right? And often we see institutional inequities in the public and private sector, as well as in public policy, driving the distribution of these social determinants of health. And there's the resource allocation of these key things, right? So there's resource allocation for the structures and the spaces, for example, of public housing. And we can think about the absence of universal access to a living wage as being some of those factors that might be driving some of the living conditions within public housing. However, we have to still go further upstream to social determinants of health inequities. These systems of racism, sexism, heterosexism, ableism, et cetera, to see how access to resources and healthy living conditions are inequitably allocated or distributed, especially institutionally, across pre-existing hierarchies of power. And so in order to sustainably drive towards health equity, we must think about ways to improve our communities further upstream. Otherwise, we're continually working downstream on the downstream results of larger inequitable structures without some of that sustainable change. That doesn't mean not working on those downstream factors, but working on both in concert, right? Otherwise, we could go down the road of providing band-aids or even victim blaming through interventions that are not getting at roots of health inequities. And in short, in order to have this true impact on health equity, which is my goal, we must be committed to dismantling structural racism from my standpoint and operating with an eye towards the systems that we are a part of. So I conduct my work utilizing an eco-social theoretical framework based on the work of Nancy Krieger, as well as this public health critical race praxis, which Collins Arambua and Chandra Ford developed as an application of critical race theory to the field of public health, and is distinguished by its focus on applying CRT empirically to any study, regardless of its design. And as with CRT more broadly, scholars utilizing it who are focused on issues of health equity concentrate on answering two main questions. First, given the multifactorial nature of disease and the primacy of racism, how is racialization relevant to this racial or ostensibly non-racial problem at hand? Secondly, because it considers social context, including the social context in which research is generated, to be inherently racialized, it simultaneously asks, how is racialization relevant to the production of knowledge about the problem? That's a lot of words, right? And the question is, what does that really mean? And so at the heart of this is the idea that race is a social construct. So through processes of racialization, distinctions between races, and the importance of phenotypic or genetic traits are driven by cultural, historical, ideological, geographical, and legal influences. So processes of racialization begin by attributing racial meaning to people's identity, and in particular, as they relate to social structures and institutional systems, such as housing, employment, and education. In societies in which white people have economic, political, and social power, processes of racialization have emerged from the creation of a hierarchy in social structures and systems based on race. And so this racialization produces racial categories that are inherently hierarchical to one another, relative to one another. That is, that race derives meaning from kind of differentiation of groups and not from some precise measurement of some essential thing or key measurement of a characteristic within a group. Furthermore, racialization is happening all around us all the time and has happened for many years and decades, centuries, right? And it's permeating elements of our day-to-day life all over, right? And race operates as a marker of that racialization in a society and becomes salient because of society-specific and time-specific racialization, which applies to a range of different groups that have been racialized over time. In this, the formation of and distinctions between races is inextricably linked to processes of both racialization and racism. And to be clear, racism is not a collection of isolated acts that are bundled together. Racism is an organized social system in which the dominant racial group, based on the ideology of inferiority, categorizes and ranks people into social groups called races and uses its power to devalue, disempower, and differentially allocate valued societal resources and opportunities to groups defined as inferior. And in the words of Ta-Nehisi Coates, race is the child of racism, not the father. And of particular interest to me is the concept and kind of elaboration of structural racism. So, we usually are thinking about interpersonal racism when we hear the word racism, and thinking about kind of discrimination between individuals. We've even delved into a lot of institutional racism in terms of key actors, key institutions that may be operating in a discriminatory manner. But structural racism refers to the totality of ways in which societies foster racial discrimination via mutually reinforcing inequitable institutions and systems. And it's really that focus on those interconnections between institutions, right? Propping up inequities in different sectors, in different institutions, different systems. And so this reinforces discriminatory beliefs, values, and distribution of resources. And in short, structural racism helps justify and maintain racial hierarchies and racialization. So when empirically trying to capture these processes, there are different ways to approach this work. The very base level of empirical inquiry would focus on the explicit consideration of variations by race and ethnicity, and kind of exposure to racism of different forms within a research question or intervention. I'm still surprised in discussions with different colleagues saying like, oh, we can't really say anything about, race or racism from the, from the work that we do without really like fully grappling or considering race, racialization, and racism within their work explicitly and, thoughtfully. There's ways of doing this even when you have limited data. One way of doing this is through empirical, is specifically through operationalizing pathways or mechanisms of structural racism. And this may involve highlighting key processes of racialization as they relate to health. For example, Nancy Krieger's work investigating the role of exposure to Jim Crow laws in relationship to cancer, so triple negative breast cancer and other cancer outcomes. This could also involve suggesting or evaluating actions to counteract processes of racialization and or mitigate the impact on health. So, these processes are happening, right? And how do they impact health? How does it get under the skin? It's through some key pathways that could be direct or indirect. So we can think about socioeconomic deprivation, exposure to toxins and hazards, social trauma, targeted marketing of really harmful commodities. We could also be thinking about kind of indirect pathways through kind of stress mechanisms and neuroendocrine disruptions, or even health-harming coping behaviors. So there's different ways of tackling it and focusing on key pathways and determining what you're going to be delving into, investigating and delving into evidence for. However, when we're talking about policies, especially since we've moved a little bit away from Jim Crow and maybe some race explicit policies, people have been a little bit more creative in terms of the kind of structure of policies, and a lot of the policies are applying to the whole society, right? It's a global nature of some of these policies that are producing this racialization, right? So, we can't simply assume that historically marginalized, racialized groups would uniformly be negatively impacted while dominant racialized groups benefit. So based on Patricia Homan's typology of structural sexism, from a kind of cross-sectional standpoint, we can hypothesize at least 3 empirical relationships between structural racism exposure and health among dominant and non-dominant racialized groups. So, what I just described of that kind of duality would be consistent with a kind of zero-sum racial conflict typology, where we would expect higher rates of disease for non-dominant racialized groups and lower rates of disease for dominant racialized groups with increasing structural racism exposure. If there are null effects, gaps between Black and white Americans, life expectancy, for example, would remain. We would still see a gap potentially by other mechanisms, but it would be independent of structural racism exposure. But if we think of universal harm, both dominant and non-dominant racialized groups will fare relatively badly with increasing levels of structural racism exposure, but non-dominant racialized groups may fare disproportionately worse, right? So all of these kinds of relationships are possible from the data that we look at, right? There's also other relationships we could see, but these are the main ones that kind of delving into. And the issue is thinking about what the exposure is and how we're measuring that, and what are the outcomes in the particular relationships and the pathways that we're delving into. In addition, add a little bit more layer, another layer of complexity is thinking about the idea that these processes of racialization and racism are occurring somewhere in relationship to time, not just secular time. So the measurement of structural racism always should be paying attention to kind of sensitive and critical periods of exposure to key pathways, key exposures occurring over time during the period when diseases are developing, including through like the duration of exposure, and historical policy and social dynamics at play by which race becomes a salient social construct. So when someone is in the course of their development, it is important for considering the potential role of exposure to some mechanism of structural racism. For example, let's say some of my work is focused on the role of incarceration on tobacco smoking among Black men in the United States. I would want to know when in their life course they were incarcerated. And really thinking about, from a life course perspective, potentially early adulthood, playing a potentially stronger role, a sensitive period, perhaps, impacting future trajectories of employment, civic engagement, et cetera. However, that depends on the person that is exposed and when. And disinvestment in public education, public services, and over-policing may be particularly relevant for childhood and adolescence, requiring data about key indicators of structural racism at the particular secular time period when the stage of the life course is relevant. So where in time are we at that developmental period? For example, we could also think about the idea of gentrification, racialized gentrification, being particularly impactful for those in middle or older age in terms of maintaining social connections, being able to access key resources and aging in place, and that being time bound. Further, living in a segregated and disinvested neighborhood, given the context of the war on drugs and the Anti-Drug Abuse Act and the 1994 crime bill, so on and so forth, it interacts with the passage of time and the stage of the life course. So this sounds massive, right? It's a really big, broad phenomena. Seems even too massive to even really think about and consider, right? But I think from a theoretical foundation of public health critical race praxis, we're never going to get all of the elements and wrangle in that octopus, right? We're not going to get all of it. However, it's still a useful framework to be thinking about the interconnections between different parts and how we might capture that both from relationships cross-sectionally, but thinking about that over time. And we can capture this. We can point to key intervention points and delving into, hopefully, structural solutions, but also other interventions at different levels. So I've spent a lot of time about thinking about like measuring mechanisms of structural racism. And one of the key elements that I think about is the criminal legal system. And I've delved a lot into incarceration. And it's one of those key linchpin dimensions of structural racism in the United States. And again, in our leadership as a nation in inequity, we're kind of a leader again in incarceration. And we experienced a really rapid period of acceleration from 1980 until about the mid-2010s, which is not a random increase. It is a exponential increase that's related to racialized social policy, namely the war on drugs. And so these policies include kind of key policies, kind of removing judicial discretion for many drug offenses. So read algorithm, mandatory minimum sentencing, how that the removal of discretion can hasten inequity. And thinking about heightened sentencing for most minor offenses. And this is something that's not happening just mass, right? Like we hear mass incarceration, we think everyone's experiencing it. However, no, it is very concentrated. And there are racial and ethnic and socioeconomic components whereby Black Americans have borne the bulk of the burden of sentencing charges, including among those who are high school dropouts or have without a college education. And with an estimate of, this might be a little bit, this may have improved since the last estimate was created, but 1 in 21 Black men currently incarcerated, and about 1 in 3 Black men, incarcerated at least once in their lifetime. Incarceration status and history represents a key social determinant of health and health inequities, and a key instrument of structural racism. And it's distinct from race and class, and has very particular implications on political disenfranchisement, access to employment, access to affordable education, housing, public benefits, et cetera. And it interacts with race and ethnicity, gender, and class. And so that got me thinking about relationships to cancer and cancer risk factors, where we already see that incarcerated populations do have a greater cancer burden, but a lot of those mechanisms seem to be focused around key lifestyle factors and behaviors, including smoking behavior. But it can be impacted by a range of different factors, and tobacco behavior, like tobacco smoking behavior and specifically, has a range of different levers, different factors that are driving the patterns that we see, from genetic to macro policy, including cigarette excise taxes and kind of policy implementation. But when it comes to incarceration, it's particularly salient that tobacco is an integral part, or has been an integral part, of prison culture as a stress reliever or currency, means of social interaction. And until the 80s, cigarettes were freely distributed as part of rations, right? But we've implemented key policies, bans on smoking to varying degrees of success. And so what we've known is we don't know a lot about what happens, comparing pre-incarceration behavior versus, characteristics of populations that are currently incarcerated, right? So there's a little bit of a tension in terms of what we know. And then thinking about trajectories, we don't know what the role of incarceration may play in smoking trajectories for key groups in this country. And so I conducted this analysis now, quite a few years ago, cross-sectional analysis in the National Survey of American Life, which is a data set of English-speaking US adults sampled 2000 to 2003, including non-Caribbean African Americans, Afro-Caribbean Americans, and non-Hispanic white folks. It did not, however, include institutionalized populations or anyone on military bases or reservations. And the exposure of interest was history and duration of adult incarceration, and the outcome was current tobacco smoking. And so using SAS and SAS Callable Sudan conducted kind of propensity score matched analyses among African American and Afro-Caribbean participants, where propensity scores were constructed utilizing age, ethnicity, personal and family mental illness, nativity, parental SES, welfare status during childhood, presence of a biological father during childhood, urbanicity of childhood home, child abuse, witness of, being a witness of domestic violence, and problematic substance use during childhood. And in that matched sample, I fit gender stratified fitted logistic models. And this resulted in 5,191 Black respondents, with 14% of them having a history of incarceration. Just think about that. And in that fully adjusted model for these analyses, formerly incarcerated Black males had 1.77 times the risk of being a current tobacco smoker compared to their counterparts without a history of incarceration. After adjusting for even further adjusting in that propensity score model. And the results were pretty similar amongst Black women and maybe a slightly lower magnitude. And in subgroup analyses among those with a history of incarceration, only one kind of prevalence ratio was statistically significant in the first model of with males. But the point estimates suggest possible trends in risk of current tobacco smoking by duration of incarceration for both males and females. And likewise, there might be a possible temporal trend by the year of first incarceration among men, with elevated risks of smoking among men incarcerated prior to 1980. So thinking about that from a policy standpoint of what was going on in that time, and rations and all of those things, the environment there. Although none of those are really statistically significant. And so from these results, I concluded that among African American and Afro-Caribbean individuals in the United States, history of incarceration was consistently and independently associated with a higher prevalence of current tobacco smoking in both men and women, with duration of incarceration potentially contributing to that relationship. And so this approach allowed me to capture some dimensions of hyper-incarceration, a key linchpin component of or dimension of structural racism, and highlighting populations at particular risk while identifying potential policy interventions for key components that are driving some of the hyper-incarceration. However, one of the key elements that when we think about that whole idea of structural racism is that it's thinking about incarceration in one dimension. It's unidimensional and it's missing some of those interrelationships that may be key to the concept of structural racism. And so structurally racist policy, like those supporting hyper-incarceration and hyper-policing, has impact on the lives and deaths of individuals and communities, right? And this image developed by Anusha Vable from my 2017 Lancet paper seeks to depict graphically the mutually reinforcing inequitable systems operating within a society steeped in structural racism. And by following some of these arrows, we can highlight pathways by which in this country you can suffer from a felony conviction for the rest of your life. So first, we can talk about the fact that a felony conviction fundamentally impacts the type of job you can get in the United States. It impacts what jobs you have access to, how you might be compensated, and the level of job growth you may be able to see over the course of your life. And in this country, we tie our healthcare to our jobs. So a felony conviction will impact the ability to access healthcare and the quality of healthcare that you may be able to receive. And again, employment impacts how much money you'll be able to make, and it's driving your ability to pay your bills, for example, and which can also impact your credit. And both your employment income and credit impacts where you can rent or even live, and if you have the ability to buy a house, right? And in this country, we tie funding of the public school system to property taxes. So where you live affects the quality of the education your children receive. So that criminal legal system involvement then has intergenerational impacts. And furthermore, the criminal legal system involvement impacts your ability to access the social safety net, or at least what's left of it, right? And not depicted in this graph, but especially important right now, a felony conviction also can affect your ability to vote, right? And be able to be civically engaged in key processes of social life. And a simple analysis of incarceration status and health is going to miss a lot of these dynamics at play, especially when understanding how structural racism operates. So further work that I'm doing focuses more on some of those interrelationships and pinpointing those and points of intervention. And so we can talk about incarceration, but there's another very common example of a mechanism of structural racism that has been delved into quite a bit in the literature, which is residential segregation. It's another linchpin key dimension of structural racism that seemingly operated through the housing sector, but it was propped up and facilitated other institutions and sectors in their discriminatory policies, whether they be colorblind or color explicit. So, in the United States, we have homeowners Loan Corporation creating an inventory of all residential areas in the US to assist banks in making loans by literally color coding the denial or limitation of financing and refinancing to certain neighborhoods based on racial and ethnic composition. This is often referred to by that term redlining, where green areas were the best, lacking a single foreigner or Negro, while red areas had been infiltrated by Black residents and other undesirable populations and were ineligible for Federal Housing Administration backing with lasting effects. So again, redlining is not just a clustering of people. It's not just, people are living in different places. It concentrated investment into white suburbs while simultaneously segregating people and hastening the decay of the inner city. And so redlining operated alongside pre-existing and subsequent policies like restrictive covenants, which have been studied at length here in Minneapolis, which are enforceable agreements on how land could be used, for example, restricting to white residents, disparate impacts of zoning and land use policies, and thinking about discrimination in historical and current rental and mortgage markets. So this sets the stage for colorblind distribution of resources over time through environmental hazards, all those pathways that we already talked about, state-sanctioned violence and municipal disinvestment. Therefore, through the structural racism, or that component of structural racism, of segregation, redlining and benign neglect are teamed with restrictive covenants, zoning, and neoliberal kind of market forces, as well as the Discriminatory Act, Social Security Act of 1935, unfair school funding, concentrated policing, et cetera, so on and so forth, over the life course, across generations, and across domains to produce differentials in intergenerational wealth, education, income, exposure to concentrated poverty, and intergenerational exposure to low quality schools, hospitals, jobs, et cetera. So essentially, redlining has essentially has been studied quite a bit and is gaining like a kind of a revival in the literature with regard to health, where, it's associated with greater historical redlining has been related to increased minority presence, as they define, higher prevalence of poverty, greater overall social vulnerability. And there's statistically significant associations between greater redlining and general indicators of population health, including increased prevalence of poor mental health, chronic health conditions, and lower life expectancy at birth. So on average, life expectancy is lower by about 3.6 years in redline communities when compared to communities that existed at the same time, but were graded highly by the Homeowners Loan Corporation. And so even more work has been done beyond redlining into residential segregation, utilizing different measures developed by Massey and Denton in the 80s, right? So they went into a deep dive, a deep exploration of dimensions and measures of segregation, including, within evenness, clustering, exposure, concentration, centralization. There's a range of different factors. And in fact, Nancy Krieger and colleagues have innovated to utilize the index of concentration at the extremes to encompass polarization of privilege and marginalization based on both race and socioeconomic status, assessing the relationship between economic segregation, racial and ethnic segregation, and racialized economic segregation and population health. And so I utilize this measure in some of my recent work focused on ovarian and breast cancer. And in this first analysis, we conducted a retrospective cohort study of malignant epithelial ovarian cancer cases in the Florida Cancer Registry, so between 2001 and 2015. And using these 5-year estimates from the American Community Survey, our research team guided by the then doctoral student Ashley Westrick, computed 5 ICE measures of different focus, right? So kind of the income focus, there's the racial and ethnic focus with both using Black, white, and Hispanic, Latinx white comparisons, and then racialized economic segregation measures. And we fit random effects frailty models for that. And among the 16,431 malignant cases diagnosed in Florida, we found that economic and racialized segregation influenced the survival more than just the racial and ethnic segregation alone for both non-Hispanic Black and Hispanic Latinx women. And for non-Hispanic Black women, they continue to have increased hazards, compared to non-Hispanic white women after controlling for multiple covariates, whereas Hispanic women had either similar or decreased hazard of death compared to non-Hispanic white women in those models. Did a similar analysis, but focused on breast cancer. We found very similar things, but we saw impacts across all the racial and ethnic groups, right? Pointing more towards a universal harm hypothesis. And so again, we were able to do much with that kind of analysis, but again, we were getting into pretty unidimensional, not really capturing structural racism. And so I've gotten more into kind of getting at multidimensional structural racism. And so there's been ways that people have kind of created these ratio measures across kind of voting, employment, political participation, et cetera, and created a kind of key measures, right? So Lukashko et al. And Wallace et al. Have created these kind of separate kind of racial inequity measures and been able to try to conceptualize some of that kind of relationship. So found some consistent relationships for myocardial infarction and for infant mortality rates. And then even more recently, there's been more of a focus on kind of these composite measures, right? So being able to think about weighting some of these key things and see relationships across multiple domains. And so Doherty et al. Estimated through confirmatory factor analysis, kind of a key approach which empirically determines the degree to which each indicator is weighted in the composite estimate, which may change over time geography and data set characteristics, which I think may be problematic for some of the ways that we're going to be studying multidimensional structural racism. More recently, Rachel Hardiman and et al. Have also created a composite measure. And while it is less constrained than the confirmatory factor analysis, it has typologies of structural racism that might be less applicable for comparing across time periods and geography. And so this has driven some of my more current work, my current and future research directions. So I'm going to fly through this since I'm over time, but I developed a measure that can be used. It is more tied to, it does not change dimensional weighting over time or by data set, and allows multiple levels of comparison. And it's using geometric means through a method very similar to a gender inequality index developed by the United Nations Development Program. And I've been using it and validating it through the Florida Cancer Registry. And I am continuing to validate and optimize through the Black Women's Health Study and the MaxWise data set as well, study. And so much of my future work, and maybe you can ask me about it, whether in Q&A or in subsequent conversations, is focused on kind of actionable policy change and thinking about that from a standpoint of kind of racialized impacts of kind of tenant protections and housing and the potentials for future work. And then thinking about racialized gentrification and displacement and healthcare utilization. And then thinking specifically about tobacco policy and racialized implementation. And all of this is only possible with key connections and partnerships with community organizations, community organizers, and being able to link that back to policy. And with that, I will thank you, particularly the Bailey Structural Inequities and Transdisciplinary Health Lab, and all of my partners and this audience for your attention. So thank you.
We've got about 10 minutes for questions, which is good. That's fantastic. Thank you for your wonderful presentation. I'm going to sit back down and monitor the Zoom in case anybody wants to put a question in the chat for me to read. Otherwise, we can take questions from folks here in the room, or if folks in Zoom want to unmute, hopefully that will work as well.
Thank you. Go.
So you started by talking about the 4 leading causes of disparities in longevity.
Mm-hmm.
and cancer and homicide, etc. And I wonder, given the tour you've led us,
Mm-hmm.
is that the wrong way to look at things? What would the message be if the 4 leading disparities were number of days or years incarcerated, number of days or years without health insurance, number of days and years, and other things like that? And what could be done in reporting health disparity statistics and mortality statistics and other things like that in a way that actually neutrally, credibly, and effectively links them back to structural causes?
So Joe, you're right on my wavelength, right? So I think it speaks to where we are as a field in public health, that we're still very much focused in these like disease sites and, you know, causes of death, and focused in on the kind of medicalized causes, and you know, what's going to be reported on a a medical examiner's report and that sort of thing, where I think what we're seeing is that there are these social upstream factors, incarceration, these range of different factors that are driving multiple outcomes and patterns in multiple outcomes. So I would love to see us report causes of death or the contributions of inequities in that way, and pointing to those key factors and focusing on how we modify those key factors, because as we go forth, then we can get into some of the implementation for particular diseases, but getting at those structural factors, they're not going to be only specific to one health outcome. We see this over and over again. So thank you for that.
Maybe just one suggestion, because I don't think you can get there in one hop.
No.
What I've never seen are statistics that say, oh, what number of people died of a cancer that would have been treatable if that person had had access to the medication, the surgery, or the doctor care that the population on average has access to for that cancer.
Mm-hmm.
So to take that first step of saying, well, wait a minute, this is something that we normally think of as a preventable cause of death. It gets a lot harder.
Yep.
But one could imagine a very similar measure around homicide in excess of the level normally tolerated by society and its overall structure of policing, other things like that.
I think that's a really good point, because I think there is an estimate for residential segregation, which I can't remember the exact details of right now, but that's pointing to one of the mechanisms. So if we were able to at least say that for multiple of these dimensions of structural racism, I think there's a larger leverage and a communication point with that data. So thank you.
Seems like a lot of the kind of measures, mechanisms lead to stress, which in turn leads to poor health outcomes, right? So what role do you see in terms of global stress interacting with these larger forces, right? And leading to poor health?
So I think stress is a very key both psychological measurement, but also a physical manifestation of a lot of these key structures, and one of the ways by which these structural forces are embodied. And so I think it is a key intervention point to mitigate some of the impacts, where I think being able to think through stress management is important. However, at the same time, understanding that the constellation of stress is not going to be completely taken away by a mindfulness intervention, right? Right. So I can speak from experience, once I left the mindfulness intervention, I'm like, okay, and then now my life, right? And so so I think there's a lot of structural forces. So then, you can manage some of the elements of stress, but then also have those other more structural barriers. I think it's key. It's a key part of it, but it's one component of that larger constellation of things. Oh, I don't know who raised their hand first.
Okay, so a thread I saw through a lot of your work is understanding temporality, but also the impact of policy. And I'm looking specifically at where you're located in Miami, and thinking about how do you think measures that have to look the Black folks, especially. Well, this one Black folks, because also have immigrant Black folks, Black Latinx. How do you create measures that capture the diversity of Blackness, and what does that look like?
That is an excellent question. So I think there have been ways. It's one of the reasons why I've delved into different kinds of measures. Because thinking about different places like Miami, Florida, the universal measurements don't really apply that well. They're not that useful. So we have to be thinking about different racial hierarchies. And I think there are also localized social hierarchies, right? So this is my hesitancy about some of the global measures and composite measures, because it doesn't capture some of the way that structural racism is operating in local place and the different people who are involved. I think it involves asking different questions of race and ethnicity and how people are describing themselves or interacting, and how what communities they're a part of. But then it's also thinking about how people are interfacing with systems locally, right? And I have found that it's actually better to move away from some of the quantitative measures and move towards more qualitative experiences in coordination with trying to develop different measures to capture that. Haven't figured it out yet. There's no measure. I haven't figured out that measure, but I think one of the first steps is moving away from just a black-white binary, right? And thinking about different comparisons and different kind of contrasts. Jenna?
There was a question in the chat.
Okay.
So first starts with great presentation. Thank you so much for your time. And then I'm curious what some of the actionable policy changes you're interested in being implemented as a result of your.
Right. Okay. So I can speak of one of my projects, which is focused on COVID-19 eviction moratoriums that were implemented. This wasn't just like, so it was in coordination with a community organization that's my partner, Community Justice Project, and consultation with community organizers, Miami Workers Center and Florida Rising, and thinking about what we were noticing in terms of what's happening after every natural disaster. We see a range of evictions, displacement, and then subsequent revitalization and gentrification, right? So we were seeing these cycles over every natural disaster. So we took into account the idea and take advantage of the natural experiment of COVID-19 and the eviction moratoriums as one policy intervention that could be possible for ensuring tenant protections. That's something that doesn't have to just be associated with COVID. It could be implemented after every disaster. That's a decision-making point. And so through some of that work, a lot of qualitative work with people who were implementing and part of the process, it's pulling out that people, I think up until that point, didn't even think of it as a modifiable factor, right? They didn't think about it as a decision point, right? But after COVID-19, I think it mobilized a lot of folks towards thinking about different tenant protections after natural disasters, after key disruptions to daily life, right? So thinking about that. However, through that work, we also realized that these are adapting systems, right? So we realized that a lot of our housing is not operated through formal courts, right? And so a lot of the evictions that took place were more about intimidation. They're about people who are living in, a back room of someone's house where they don't know what their rights are in terms of they didn't sign a formal agreement or didn't have necessarily the legal advice for some of those key components. So there's an element of right to counsel as being for people facing evictions of different kinds, right? And that being a policy intervention or potential intervention point. But then also, I think there's another aspect of this in terms of a broader range of tenant rights and tenant protections. And there are people who are mobilizing on the ground with that. So through the course of the pandemic, Miami Workers Center and others have mobilized to develop a tenants bill of rights for Miami-Dade County, which is unheard of and relatively unheard of in the state. We have like no protections, right? So it's something that can build in terms of being more of a protection for folks, and thinking about non-court, necessarily court interventions or focus in actually mitigating some of the impacts.
Well,
I'll
we're,
take a question.
is there another question?
Yeah, go ahead.
Mhm.
What would you suggest to like bring about when identifying intersectional identities, in terms of the visualization process for Latin communities?
Mhm.
Very
Mhm. I think this is going to be a longer conversation that we should delve into, but my short answer to your question is, like, we need to move beyond what we already have in terms of being able to kind of put together kind of racialized immigration status as a key component, because it's reflecting a trajectory of historical policy around how this nation interacts and interfaces with other countries and people from other countries. So yes.
Thank you so much.
Thank you. Thank you.
Thank you all for being here. We appreciate it. Dr. Bailey will be here through tomorrow, and we all look forward to spending more time with you. And you have a few minutes before your next.
I think
Okay, we
so.
want to make sure to get
Yes.
her to her next meeting. But thanks again for being here, everybody. And yeah, I don't know what else to say.
And thank you to those on Zoom.